Please note, the opinions expressed in this podcast are those of the individual speakers and do not necessarily reflect the views of Tri-County Orthopedics. Any medical advice or treatment recommendations discussed should always be reviewed with your own healthcare provider. This podcast is not a substitute for professional medical advice, diagnosis, or treatment. All right, welcome back to the OrthoZone. I'm Dr. Stephen Hunt, part of Tri-County Orthopedics, and it's my pleasure once again to welcome our president, my partner, Paul Lombardi, to discuss a different topic. So, Paul, thanks for being here.
Thanks, Steve. Thanks for having me.
So, what is it that we're going to talk about today?
So today we're going to talk about hip resurfacing.
Okay. Hip resurfacing, I hear that a lot from patients who, when I talk to them about an arthroscopic hip surgery, try to explain that that's a totally different procedure. So what exactly is hip resurfacing?
So as a joint replacement surgeon, when we replace the hip, there's really two options. Hip replacement is the standard way, and typically what we do is we actually cut the entire ball of the hip off and then replace that with a metal stem with a head on it. With the resurfacing, essentially what we're doing is we're going to dislocate the hip, take away the bad bone on the ball, and put a metal cap on it. So it allows the patient's native normal bone below the diseased femoral head to stay in place, and it restores the normal anatomy.
So in terms of it being different from a conventional hip replacement, I guess we would say it's a little more bone preserving on the thigh bone side or the ball side, correct?
That's correct. The socket side is essentially the same type of procedure in which we take away the diseased cartilage in the socket and we put in a new metal socket. On the femoral side, we're really conserving bone for the future. That's correct.
And so hip replacements have evolved tremendously. I think we kind of discussed this when we talked about outpatient joint replacement. So why would someone choose to have a hip resurfacing? Who are the patients that you think are ideal for that and why?
So I do roughly about 400 to 450 hip replacements a year, and I do about 20 hip resurfacings a year. And I think that the hip resurfacing is really indicated for the active, healthy, young male. Unfortunately, the scientific data that's been done on these patients shows that women, for whatever reason, just don't respond very well to the hip resurfacing technique. So I think it's really reserved now for the young, active, healthy male.
It certainly seems, in terms of our understanding of how this procedure works, that perhaps the females may have a smaller femoral neck, so it may make them more prone to complications. Is that one of the reasons why the female population is not done as well?
That's correct. The hip resurfacing implant was actually designed in England about 30 to 40 years ago in Birmingham, and this is a metal-on-metal prosthetic. The data shows that once you go below a certain size, which is 48 millimeters, once you go below 48 millimeters, the results of the hip resurfacing is actually very poor, and most women require a hip resurfacing component that's less than 48 millimeters.
Gotcha. And so I guess that brings me to one of the other issues. So this is a metal-on-metal articulation. So traditionally in the total hip replacement, what are the components that you usually put in?
So in a standard hip replacement, we put in a metal socket with a plastic or polyethylene liner. And on the femoral side, we put in a titanium stem with a ceramic head. So the bearing surface is ceramic on polyethylene or plastic. Now in between is the normal joint lubrication, the synovial fluid that requires the lubrication for the joint. The metal on metal of a hip resurfacing basically uses the same concept. There's still joint fluid that lubricates the implant, but there has been in the past not so favorable results of metal on metal hip replacements. And hip resurfacing is a completely different engineering, completely different mechanics, so that the results of resurfacing are actually excellent at 15 to 20 years of when you follow these patients that long, the results are actually very favorable.
Right. And so when you do a conventional total hip, I guess we worry that you may wear the plastic out a little bit. That can create some local reaction. But with the metal, there's been some concerns about metal ions entering the bloodstream, and perhaps that's been an issue for considering young female patients who might get pregnant. What are your thoughts on some of those issues that have come up?
So you're correct. Actually, if you look at anybody who has a hip or knee replacement, they have slightly higher levels of cobalt and chromium. That's just the nature of having a joint replacement, and the levels that are elevated are not enough to be concerned.
And those are common elements that are in the metal part of it, correct?
That's correct. That's cobalt and chromium. Titanium typically does not become elevated in the bloodstream. In a well-functioning hip resurfacing, the levels of cobalt chromium actually stay within very safe levels.
So from a technical standpoint, if you have the right patient, you've indicated them, since you're taking less bone, is this procedure quicker procedure in the operating room? Is it technically less challenging than doing a full hip replacement?
So I tell patients that this is a bone-preserving procedure, but actually is somewhat more difficult to perform because during a hip replacement, we dislocate the hip and we basically remove the ball. We actually, with a saw, we remove the ball completely off. In resurfacing, we dislocate the hip, but we have to be able to manipulate it in a way to see it in 360 degrees so I can remove the bone that's diseased to place on that metal cap properly. So in order to get that kind of exposure, it requires more dissection and more soft tissue to be disturbed.
And of course, the patient's asleep for this part of the procedure, not to scare any patients in our audience.
Absolutely.
And so during that process, does it require additional assistance or significant equipment, or does it require computer navigation or anything like that?
So we approach it like any other posterior approach hip replacement. Currently, the standard of care is to perform resurfacings from the posterior approach. The anterior approach is very, very difficult to perform hip resurfacings and is currently not indicated. Other than that, it would be the standard equipment and the standard type of OR setup and the normal assistance.
And is there anything different about rehabilitation after this procedure versus a conventional total hip replacement?
So one of the significant benefits of hip resurfacing is that it's much more stable and less prone to dislocation. And that's because the size of the head is so much larger. A basic concept in hip replacement is as the size of the metal head or ceramic head increases, as the diameter increases, the stability of the hip replacement goes up in a logarithmic way. So that's one of the benefits. And the types of patients who I select for hip resurfacing many times are young, heavy laborers, young men who have occupations such as a policeman or a fireman or a plumber or an iron worker, where during their employment, stability of hip replacement is actually quite important, and therefore these are the types of patients that I would indicate.
And now, how do patients generally, anecdotally anyway, feel after hip resurfacing versus a hip replacement? Do you have any sense that there's a difference in sort of a more natural feel? Because it seems like you're preserving the sort of femoral anatomy a little bit better than sometimes we do in a hip replacement, where we have a little bit of wiggle room in terms of how that stem gets put in.
That's an excellent point, because one of the true benefits mechanically of a hip resurfacing is that you're completely restoring the relationships, the angles, and the types of way the tendons and soft tissues all relate to one another around the hip, because we're not actually taking off the ball, we're just resurfacing the ball. In a hip replacement, we're always trying to recreate that patient's normal anatomy and normal mechanics. And there are times we can get close to it as possible, but one of the benefits of resurfacing is that patients do talk about how it feels more normal to them because their normal mechanics have been maintained.
And the longevity of this implant is pretty long. I was looking at a study recently in JBJS from the group at Washington University where their 15-year survivorship was about 96%, which in my opinion is really good for any type of replacement procedure.
Yes, the study that you referenced was excellent science, and at 15 years, 96% is an excellent number for survivorship. There's every reason to believe, even some of the data out of the United Kingdom, that once you have resurfacing, that it's for life.
And so to that point, I guess we are talking about, sort of based on your general indications, a younger population. So I think, for our audience out there, there's a lot of young people who do have arthritis, and they're a little bit fearful about having a joint replacement because they've heard they only last so long. And so obviously, if you're on the younger side of the spectrum, you may, sort of outlive the life expectancy of any component that you have replaced. So are there issues with revision surgeries down the road for this type of procedure?
So if for whatever reason a revision of this procedure is required, that could be because unfortunately someone had a trauma and maybe fractured the bone around the implant, or unfortunately obtained an infection from some other source. To revise a hip resurfacing to a hip replacement is actually a rather routine procedure to do because you've maintained and you have kept the patient's prior bony anatomy in place.
And what about things that we also think about, like leg length discrepancy? Is it less of an issue because you're kind of restoring that normal anatomy?
That is correct. Because restoring normal anatomy, maintaining leg lengths is actually another one of the great benefits of hip resurfacing, yes.
And so if you were to summarize sort of the benefits of this procedure and sort of who in your office that you would recommend come see you to have this procedure done, how would you create that summary?
So I think that someone who is a relatively young, active, healthy male in occupations such as heavy laborer, policeman, fireman, or someone who wants to maintain the next level of activity, say someone who's really into martial arts or wants to be a century bike rider or wants to run marathons or run triathlons. Those are the type of patients that I think would benefit from resurfacing. And actually, Dr. Hunt, we could actually share this question together, which is you're someone who does a lot of hip arthroscopies, and many times we share patients who have a labral tear and potentially early onset arthritis. Who are the patients that you're going to take to the operating room for arthroscopy, and where's the line where it goes from arthroscopy to hip resurfacing?
Yeah, there's not a line. That's sort of just all different shades of gray. I think those are our toughest patients, young, active people, particularly I would say 40s to 50s. Most of us have labral tears in our 50s, but not everybody's symptomatic. But for the ones that are symptomatic, if they have a significant amount of arthritis, I usually have that conversation. Sometimes I'll even suggest they have a consultation with a hip resurfacing or hip replacement specialist because, believe it or not, sometimes the outcomes are much more predictable to have the joint resurfaced or replaced than they are to do a preservation procedure. But that's a talk for a different time. So I will say that we will attach some recent studies that really look at the comparison between hip resurfacing and hip replacement. And what you'll see is there tend to be pretty similar complication rates, outcomes. I think what I gleaned from the literature is that there's a little higher level of activity early on for the people who have hip resurfacing. So certainly is a great option. Any parting words for the audience, Paul?
So I think that if you have been diagnosed with significant osteoarthritis as a young, active, healthy male, I think you absolutely should get a consultation to see if hip resurfacing is the correct procedure for you.
All right. Well, we appreciate your time today on the podcast, and we look forward to having you back to discuss in the future.
Thank you, Dr. Hunt. I really appreciate it.
If you enjoyed today's episode, be sure to subscribe so you never miss an update. Don't forget to share the podcast with others who might find it helpful, and follow us on Facebook and Instagram at Tri-County Orthopedics to stay connected. Thanks again for tuning in, and we'll catch you next time.